Hello to everybody who's logging in all around the world. We hope you are comfortable, whichever time zone you're watching from.
Well, this is going to be fun. I'm excited.
Yeah, we're going to have an interesting talk about how everybody's research fits together.
Going to be interesting for sure. Getting all that done, seeing the product after everyone's made their contributions.
Yeah, we all get to put our neuroscience caps on and then focus on the translation of that to impact patient care, which is super. I can't wait.
And the impact will be beyond patient care too. I think a lot of it can integrate into performance enhancement.
Yeah. It's kind of like a brain lab in a box.
Okay, looks like we're just hitting 7 a.m. So people can still join in throughout. So perhaps Ryan, I'll turn it over to you if you want to kind of kick us off, and then we can kind of get the show started.
Awesome, thanks, Adam. So good morning, everyone. We are excited to put this on virtually, and what this is I think a really what should be a really exciting conversation between a number of people who are absolute pioneers in addressing the problem that there's I think a global need for an objective neurophysiological measure of brain function that can deploy anywhere and be rapid and utilized outside of our laboratories, on our rink sides and our field sides and our ICUs, our rehab settings, and our hospitals. And also power up in interesting ways our human clinical research and our human basic performance research. So I'm excited to talk about it. Certainly stems from a lot of work starting from 1995 till now to look at electrophysiology and particularly event-related brain potentials and translate them. It emerged as a concept that there should be a vital sign for brain function. So that if we have vital signs for heart, why can we not extract some simple neurophysiological measures that are vital signs for our brain function? And that, of course, emerged then as what we know and love as the NeuroCatch Platform. And we have the amazing panel today together, facilitated by Wilf Nelson from Water Cooler Neuroscience. And then really coming along the spectrum of different degrees of applications and severity of brain injury. So we have Ainsley Smith from the Mayo Clinic, who's a longtime collaborator in concussion. And then Mike Gesser from Alberta Children's Hospital, who's a pediatric neurologist and is seeing children with concussion and more severe brain injuries who are coming into hospital. And then rounding it out in terms of severe brain injury and disorders of consciousness, we have Sudhin Shah from Cornell University, who's using this to look at functional status evaluation in severely brain damaged patients. So with that, I'll pass it over to Wilf. I'm excited for this morning, and thank you everyone for joining.
Hello, everyone. And yes, particularly thanks to those on the Pacific Coast hosting this very early in their morning. We thank you for setting this up so it's more comfortable for the rest of us across the world. So how this is going to run for everybody who's interested, we're going to start talking about NeuroCatch. We're going to have a short 10 minutes at the beginning where we're going to talk with each of our pioneering panelists about how they use NeuroCatch in their work. And then we're going to go into some of the more specifics. But we do have a Q&A function down here. That will be seen by all the panelists if you want to ask any questions. So don't feel worried at any point. If you want to ask something, if you want us to steer the conversation in an area you find particularly interesting, let us know. We will see, and I will make sure that happens. So I guess starting off with Ainsley. Ainsley, could you tell our audience, how has NeuroCatch been used, as you said, rinkside, working with concussions, working with people really, quite recently after their injuries? What's NeuroCatch doing, and how is it letting you use this brain lab in a box, as Ryan called it?
Well, it's really a wonderful asset for us to have and know that it is capturing some of the brain signals. And we do that in our practice by studying everybody first in baseline and then following concussion, again, before they return to hockey or to play, and then postseason. So we really like the opportunity to have the repeated measure design and know that the data that the NeuroCatch is picking up is going to be very, very helpful. So that data gets sent over and is interpreted by Sean and Ryan. Thank you.
So, Mike, as we said, you're slightly in between where Ainsley and Sudan are. You're working with people who've had more long-term concussions and injuries. Could you explain again, where is NeuroCatch coming in when we see a patient that perhaps has a more chronic condition?
Yes, thanks, Wilf. So, I've been looking for a long time for a more objective measure of trying to figure out why patients and kids, because I work with kids, are not recovering, whether it's a concussion or a more severe brain injury. And our clinical exam is very good, and often motor recovery comes faster than what cognitive complaints are. So it's not always easy to tease this out, especially in an outpatient setting. So NeuroCatch gives us an opportunity to get objective measures of specific parameters of brain function that's quick and easy. And it's something that we can do serially over time to see how patients recover in the context of any therapies we institute, but also in terms of their brain function as objective measure as well as subjective.
And we should also mention that part of why NeuroCatch has been used, and we've had discussions about NeuroCatch, is it's not like a standard EEG system where you've got all the cables and the amps and the, it's not as cumbersome as a normal research EEG kit that you train with undergrads and masters. So I guess when you are looking with these chronic patients that may struggle to get around more, they may have lost some of their mobility, you can take NeuroCatch to them if you'd like. I mean,
Yeah.
there is an ease there.
Yeah, for sure. And it's really easy to do. It's just a cap that goes on. My research team puts it on and they're very efficient at it. Within 20 minutes, they have a full scan. We have the data right away. And for patients that are in ICU, where it's a bit more tricky because of lines and other issues, it's still not difficult to put on. It's not something we're asking that's on for a long time. So the ability to do a test and repeatedly without the invasiveness or the cumbersomeness of some of the other modalities is actually a huge attracting factor.
Okay, so Sudan, bringing that through to the very academic side, wanting to study these, looking at the patterns, looking how brain activity is changing, not ringside, but in a lab for the knowledge of academia. How is NeuroCatch working in that regard, and what's it working to help you do?
Right. So as you said, most of my research has primarily been in the lab, but we, using NeuroCatch, have been able to get to the clinical bedside much more easier than our previous attempts with previous EEG systems. So NeuroCatch basically helps us take what we want to do, which is measure objectively cognitive function, to the bedside, from the lab to the bedside. And studies in our lab focus on recovery after severe, moderate to severe brain injury in both children and adults. So we collect EEG in children who've had really bad injuries and are in rehab or in the acute setting, and then we track them as they recover function. And NeuroCatch has been a huge aspect of being able to do this feasibly at the bedside.
Great. So for our audience, like I said, if you have any questions, pop them in, but that's the basics. You can see NeuroCatch is giving you two real advantages, and obviously Ryan can join in about the others, but the two we've covered are, one, that it's very portable, it's very quick and easy to set up, which helps as you're looking at with patients who don't have a lot of time to give us, who aren't able to come in and do extensive studies. NeuroCatch is very responsive to their needs, and also it has built-in functions that allow for replicability, the standard of science. You can scan somebody on day 1, scan somebody on day 100, and it lets you know how they're doing rather than manually doing that by checking over scans. So I guess, Ainsley, I want to be curious. I want to talk to you then, and if any of you other panelists have opinions about this, then let me know. How are you setting up your studies now with NeuroCatch in mind? Because it's a different technology. So, when you start off with a new technology, you always view it as the old technology, just a bit changed. But as you get more used to it, you start to see, how is that changing so that you start to view NeuroCatch in a different way? And how does it alter your thought patterns as a researcher to now include it?
Yes, I'd like to kind of describe the folks that I'm working with too, and the role that they play in contributing data. And my association with the NeuroCatch, just so you know, goes back to meeting with Ryan Darcy in a hotel cafeteria way years ago and seeing it sketched out on a napkin. And so I've just been excited to see the way it's moved to being really quite rapidly applied. And it's down to, I think, about total of 6 minutes involving our players. And we're looking at junior A hockey players. And I don't know how many of you know, but they sustain huge accelerations to the head. Every time there's a body check into the boards, every time there's a fight, the accidental collisions, the hard surfaces they're landing on, they're getting head trauma. And we've used for many years instrumented helmets so that we were able to measure the amount of rotational acceleration to the head, the amount of linear acceleration. And it's a very concerning population to work with. So having the NeuroCatch and seeing it evolve to where it's at now, where I think, Ryan can correct me, but I think they're getting, my research folks are getting the cap on and collecting a full piece of data in, I think, a total of 6 minutes. And that's really fabulous. So a player can come off the ice who's taken a huge head hit, and their decisions are being made about returning them. And while we're still using the athletic trainer's clinical evaluation, the timeliness now of the QEEG into just those few minutes may end up being the basis for which a player is returned to play. And certainly, like in the Stanley Cup right now, having players off the ice, it's critical to the outcome of the game. So it's just evolving to be a most useful tool.
Okay, so Adam, I know that you have some slides that our audience can see of the kind of outputs that people are getting when they're using this by the ringside. But while we're getting to see that, Mike, I think obviously one of the questions, not just from a research perspective, but from an outside perspective is, as Ainsley's saying, they're able to see people who have got brain injuries, and sometimes the players will say they're fine. They can't feel anything, but their neural data is saying that there is something wrong. So Mike, could you jump in about what's happening there from, say that you do have players, you are one of those people who are as interested in the health of the people who are playing on your team. What happens if we were to miss something versus what NeuroCatch would help us catch? What are those kind of chronic effects we're seeing in damage? Mike, you're muted.
Busy where I am at work, so I'm trying to cut down the background noise. It's a good question, Wilf, and I think that's part of what we don't really understand and why it's critical to have tools like NeuroCatch, because while exercise and participation in the things that make everybody happy is really important for brain recovery and brain health, if you go back too soon and your brain's not ready, the risk then is that the subsequent event is a compounded effect. So, and we do see this often because the patients that come to us in the clinic are the ones who don't recover by 2 to 3 months or longer, and who have lingering problems often in the cognitive behavioral domains, not necessarily in motor domains. And so sometimes with repeated injuries, the effects of the subsequent concussions are actually compounded. They're worse, they last longer, and sometimes it leads to a point where they may not actually recover fully back to their pre-baseline level. So having tools like NeuroCatch and doing serial measurements allows us to then have that conversation with families to understand that their brain, yeah, you might feel 100%, but really the numbers are not showing the same thing. And it's a bit risky to go back soon, especially if there's a high risk of another potential head injury.
Yeah, especially when in this case, as you can see, there are cognitive process latencies. You can just show your reaction speeds aren't what they used to be. And that's tragic. And that's why we're trying to help with the treatment. But you can show a objective mathematical representation that there really is a deficit. So Sudan, as you can see, you have some of these outputs and stuff. I'm curious that, to be honest, academics can really like the methods they previously used, and NeuroCatch is bringing something new. So how are you using these kind of graphics that are quite new to the world of neuroscience into research and helping to show, rather than just presenting lines and lines and lines of EEG information that really doesn't mean much until you break it down?
So I just want to, I will answer that question, but I just follow up on what Mike was saying, because I think it helped answer this question. We deal with patients, pediatrics and adults who've had severe brain injury. So we've got the opposite in some ways problem that Mike has, which is that they don't recover sometimes in their motor function. So when you don't have motor function recovery, which is how most of cognitive testing is accomplished, then you don't know what they've recovered after the brain injury. So they can look as if they haven't recovered past, the acute stages, and they can look like that years on out. But using something like NeuroCatch allows us to get insight into what's actually happening in their brain, regardless of whether the child or adult can tell us if they heard us, they understood us, and they can follow what we're doing. I particularly like this radar plot that NeuroCatch has, because like you said, EEG has always suffered from it's just squiggly lines on a screen. And how does that translate to something that's useful to a family member, to us in research to understand, especially when we're tracking changes over time. And we've got sophisticated research tools that we use to understand, to translate those squiggly lines into something that's meaningful, but it's very difficult to translate that into something that's understandable to a family member. And so the radar plots are a huge advance in looking at change after the injury, and more importantly, change as the child or adult recovers over time. But I also like it because it's not just showing us one function of the brain. The radar plot shows us across 3 very basic functions of the brain together. So, and that's important because it's sort of like a hierarchical assessment of cognitive recovery. And you may see that one of it is impaired after injury and the others are preserved, and over time that hopefully gets better. Or it may be that they're impaired on all 3 of the things NeuroCatch measures, and then one gets better and the other doesn't. So it's that added information that you wouldn't necessarily get by just looking at one paradigm independently.
Yeah, that makes sense. So the other great thing that science needs always is validation and replication, to use more than one method to understand. So Mike, would you be able to tell us what are the ways that NeuroCatch is integrating? Because obviously when you're testing somebody's recovery, you're testing somebody's cognitive function, you won't just use one system, one test. How is NeuroCatch working so that you can add it in and not have it disrupt other research and other methods? Muted again, Mike, sorry.
Sorry about that. So yeah, that's a great question, and it's actually a very important concept. So we use NeuroCatch in combination with other modalities. So we're looking at this from the perspective of integrated multimodal analysis, because no single test is ideal at describing a patient or their situation as a whole. So we integrate it with a combination of fluid biomarkers, for example, in the blood, MRI, and neuropsych testing. And then we look at the combination of them together, and the NeuroCatch metrics are very good because they're quantitative metrics that you can then look at actual numbers, latency, or amplitude of different waveforms, and you can merge that with all this other data. And then you can say, now if I put this all together as a multimodal package, what is it telling me? And then within the context of that is, what is it telling me about certain metrics? Because what we're finding is that if you look at any single testing domain by itself, it's not necessarily that sensitive or specific at understanding or describing the injury or predicting the likelihood of recovery or prognosticating the long-term outcome. But if you combine them together, what happens is then certain parameters, for example, on N100 on NeuroCatch may jump out as something that in combination with a neuropsych profile and maybe a blood biomarker is actually quite predictive of how well the patients will do. So in that context, integrating it into a combined multimodal assessment is fantastic. And the fact that it's so easy to use and we can use it over and over and over in the same patient so that you have longitudinal data and you can look at the delta between sessions becomes very impactful in terms of our ability to help the patients.
Yeah, and for those that aren't using NeuroCatch right now, I'll get to you in a minute, Ainsley, because I wanted to ask a question, but for those who aren't using NeuroCatch right now, that longitudinal data is packaged in, isn't it? Do you say this is patient number 7, scan on day 1, and it starts to collect that for you rather than just, granted, older systems that would output a file that you would put on a hard drive and you'd have to integrate it yourself?
Yeah, exactly. So you get, as you said, patient 7 will have scan 1, scan 2, scan 3. You'll have some data related to each scan, and then you can see them all in order and you can display them different ways. So it's helpful for me as a clinician, and it's helpful to show these pictures to the patients. But also as a scientist, I'm really about the data and I want to see the data. And I don't like things that I just see a picture, but I can't see what made the picture. So I get to actually see both. So it makes me feel more comfortable.
Yes, and your research assistants must be very happy it's all bundled together so they don't have to do that part. So Ainsley, could you explain, like I said, we're looking at these multimodal tests that, one measure of neural health isn't going to be useful, but it helps you to integrate new neural tests. And as Mike was saying, you can add notes, you can add extra information of here's the biomarkers, here's the blood pressure, here's how their fluids are handling. How's that working when you are looking much closer to the event of the injury or just studying neural damage?
I just had another thought, and I'm going to just mention this first. The promptness in which you have that data from NeuroCatch is so superior to getting back blood biomarker results. And at this time, looking at neuron-specific NLAs or the SNTF, we're sending blood samples to Sweden and places like that, so that those results are not useful at all for us in interpreting how they're good for our research, but they're not real time. And so the NeuroCatch availability right at rinkside and being able to see what's happening is a great asset. When you're then telling a young person who's seeking a scholarship, he has to come off the ice. So I see it becoming, for maybe 6 weeks or something, once they're removed and diagnosed with a concussion. So the accuracy and the availability right at rinkside is critical to the players. And we're just talking about Junior A. What about the Stanley Cup going on right now? And they're bringing somebody off and trying to make an assessment. Those are critical to that player's future. And so the accuracy and the immediacy are just great assets that the QEEG is adding.
One of my favorite moments, Ainsley, from our research was when our Junior A players started to worry they had a concussion and ask for a NeuroCatch. I thought that was an amazing moment.
So I wanted to ask this question. You said it only takes 6 minutes. How much training does it take to be able to use a NeuroCatch? So if we have got, medics who aren't neuroscientists and people here are, how long does it take to train? Because it would seem like something that you'd probably want. And what's the barrier to use?
Are you asking me?
Anybody can jump in on this, but obviously, Ainsley, you have got the most direct experience.
I'll just take the initiative here first. Originally, we were having our research coordinator and research assistants go out to Vancouver and be trained in the lab with Sean Fickling and Brian Darcy. And then they would come back and be at the rink at all of the home games and take care of obtaining the data. But it's moving to where I think that orientation period is much shorter. And I think that they can be doing it we know they're doing it without having to make that trip, especially in this pandemic. But it's evolving very, very quickly to where that information is available so fast. And the athletic trainer and the team physicians can be making really evidence-based decisions for those players.
So
and then, do you want to repeat?
So it sounds like there's more use just outside. It's not just ringside, but motor sports. They can have amazing velocities at which they can get damaged, and you can't tell if somebody's damaged easily because it's bad. To be careful about what I'm saying.
Totally.
But that means that if you have somebody in motorsports or riding a motorbike or cycling even, I see that there is a space for NeuroCatch in letting you assess and check if people are injured far more than you might be able to tell at a roadside or in an outdoor sport that isn't always with a medic by the side.
Even stay in sport. We're not just talking about hockey. I mean, what about in football? And what about in lacrosse and ski racers hitting trees? I mean, there's all kinds of use just in the sport world. And then you're generalizing well, but beyond that, which is absolutely the truth. And the military, I would think, would see a huge use in it, especially when they're up and around the IEDs And some of the team physician or military physicians that I've met that were first using treatment of NAC and so on, were right up on the front lines. And I could picture this being in the tent of, the health professionals that are working with the soldiers. It's a very important device.
Okay, so to dial that a bit away from, serious accidents and stuff where obviously it does have a use, Sudan, as a researcher, I must confess that, as we said, the ease of use. Now, one of the things you always want ease of use on is with your lab techs. When you bring in a new lab tech, there is a training element, and more complex machines are always a problem in that regard because you need your more technically minded staff doing the most difficult projects. With NeuroCatch, are we looking at a way to open up that even undergrads or postgrads in their early parts of their training, NeuroCatch is probably a good system to be able to give them, rather than waiting the 6 months for fMRI training, the 7 months you have to do for MEG training?
Absolutely.
Yes.
Sorry, Nancy.
Go ahead.
Okay. EEG is by far the most clinically feasible of the neuroimaging tools. And that's even before NeuroCatch came along, and NeuroCatch just made it a lot easier, even easier than that. So yeah, we work with a very hard population, children who are very sick and are at the bedside, who cannot move of their own accord. NeuroCatch has gone a long way in helping us get clean data with minimal training of the research tech, as you said, because that's partly one of their innovations, that it's quick to put on and easy to use. The other innovation, I mentioned this earlier, I think one of the key reasons that we were very excited to use NeuroCatch is the fact that it's not just one paradigm. There are 3 paradigms all meshed into this one quick 5-minute scan. And that's very innovative, because I've been using these sorts of paradigms for years on their own, and you can collect data on somebody who's a willing participant in a lab for hours if you want on the same things. And I think one of the advantages of NeuroCatch is that you can get that same data in a shorter period of time and much more feasible, which makes it a lot easier to use with children, for example.
Yeah, and if everybody would permit me a small speculation from outside of your respective fields, that opens up to areas where neuroscience has traditionally been very uncomfortable. TV watching is something that people do over hours. Putting somebody in an fMRI scanner to watch and binge a show is something that I think a lot of neuroscientists are very curious to know what happens about why humans will watch something for hours on end when nothing's really changing and the show's very repetitive. But NeuroCatch does offer you an opportunity of, here's a comfy armchair and we'll just run the scan every a few minutes, keep watching and enjoy yourself. So I think that there's interesting space that NeuroCatch's ease is something that would be very useful. And I can attest to this myself, that, getting somebody in the lab is an event. You have to scan and train and make sure they're all safe and everything. And there's a lot of work there. It would be so nice personally to get that all removed. Yes, Ryan?
Well, yeah, I think one of the parts, Sudan, that I thought, of course, my favorite memory from your study was opening up to be able to see things we'd never seen before. So in disorders of consciousness, you could track basically emergence from coma to some level higher functioning in terms of the brainwaves, right? And that's, I don't know if we've ever had that possibility and capability up until now.
I think there are other neuroimaging studies that have done it, not as feasibly, or and not in pediatrics, for example. You've done some pioneering work in that a long time ago in DOC, but I think the advantage of NeuroCatch being so easy to use and quick to collect has opened up the applications. For example, serial assessments of a child or adult recovering is a lot easier than just this one scan that you get to, and only one chance to assess their cognitive function, which is why it's very interesting to us, because we like to track the recovery process.
Yeah, so Mike, to jump in a second, one of the things we're discussing obviously is that there is an ease of use in NeuroCatch, not just from a point about its use, but also from the ease that it makes our lives better as researchers, that we don't have to fight the machines because they are very difficult to use at times. One of the things I'm curious about then is from your side, when you're looking at these chronic patients, these patients that have a recovery, NeuroCatch should, if I'm right, be allowing you to look at their lives in more easy aspects, because when they come into the clinic, you know, they're trying, and we respect that they are trying to do the tasks, but the real complaints are, I woke up in the morning and making a cup of coffee is really hard, or I tried to focus at work and it's really difficult to concentrate, and it's not something that you can always replicate that very easily. Are there ways that you're looking for NeuroCatch to be able to help you get these more ecologically valid, but also more natural events that are quite tricky, but really part of the patient's experience?
Yeah, I think so. I think that's kind of what the appeal to this is. As you mentioned, sometimes when patients are recovering and maybe some things are getting better versus others, and it might be attention focusing, it may be daily tasks, it may be ability to function in a classroom that's more noisy and they never noticed it before, but it's a distracting capacity. So NeuroCatch then gives us the ability to say, okay, well, we'll do a recording as part of your clinic visit. At the same time, we say, well, how are things going? We do quick questionnaires like PEDS, quality of life, and you can measure things and then get a sense from them about what they perceive as their challenges. And then we try to marry that to what the NeuroCatch shows us in terms of data. So if, you know, if you look at the radar plots, and I think you saw little snapshots of them, if those are changing over time and those are fitting with the patient's trajectory, then that makes sense. If they're not fitting, then what is underlying that? And really, what is it that we need to get at to help them along their road to recovery? Because sometimes it's not easy to understand what that is you need to do. It may not be what seems apparent. For example, they may come in and complain of difficulties focusing in school, and the problem is sleep. The problem is not focusing in school, they're just not getting enough sleep. So it helps to try to get at the depth of what is underlying the inability to move forward.
Excellent. So as we're halfway through the session, I just want to remind everybody that Adam has opened up the standard chat. So if you would like to mention anything, we see, Tanya, that you have talked about how you've been using NeuroCatch as part of your training and working in physiotherapy. We would love to actually hear more about that. Please don't feel that you need to be shy about the details. I would love to hear what's going on. But yeah, anybody who wants to mention in chat, I will definitely pick you out and make sure that the rest of our panelists get a chance to talk about what you want to say to us.
Yeah,
So,
Wilf, I think it would be fun to talk a little bit about the sensitivity too, right? I know from Mike's early days, he could show me scans where he could see in the changes what he looked like and was quite comfortable was sort of concussive related changes. And I think we've been able to demonstrate across a number of domains now that there's an increased sensitivity to changes, whether or not you're looking at changes in the latencies or subtle changes in the amplitudes that have a lot of clinical relevance. And also, to your point, Wilf, and I've always liked this, we run in our basic research studies healthy individuals who we have no clue what their level of brain function is, and allowing a sort of an assessment of saying, okay, you're in normal range, gives us much more powered up research studies to understand that, rather than making an assumption, to Mike's point, that everyone who comes in is in the same level, right? We can now actually titrate that. So I think it'd be interesting to hear from the panel around their experiences with the increased sensitivity.
Yeah, let's start off with Sudhin from the academic side, because I think sensitivity there is where it's going to be most scrutinized and picked apart.
Yes, so I think even though we've had EEG for many years, we're very far away from validating that with what you said, our ecological, function, or what somebody would complain about, like I can't pay attention. Having, first of all, normative data, which is what I think NeuroCatch will help us get by making it so easy and feasible to collect this data in, for example, typically developing children. This is very important when we're dealing with children, especially because there are developmental changes in typically developing children with the EEG and their brain responses to cognitive paradigms that we don't have a very good idea about. And so it makes our job very hard when we're trying to then assess a brain injured child and a child's recovery to know whether has the child recovered enough? Is this now normal or is this abnormal? So getting more and more, where we're far from being able to say that with any certainty at this point. The best we can do is track change and see that they are getting closer to normal. But I think collecting more and more normative data, especially in the younger kids, and being able to know for sure what is change important.
Yeah, so
Wilf, may I
Ainsley,
comment on that?
I was
I'd just
literally
like to
about to ask you to
mention-
comment on that, Ainsley.
Well, I just wanted to remind too that in our own research, we don't really need to use normative data from other populations when we use the repeated measure design that we do of looking at players pre-season, post-concussion, prior to return to play, and post-season. So each player is serving as his own or her own control. And so we can see those, as I said, see those changes from the head exposures that have occurred to the players through that season, and what is left as deficits or problems at the end of that. So I understand about the need still for normative data, but in the specific research that I think can be very helpful in all sports and should be used up in the pros, in football, lacrosse, all of the contact kind of sports, I think if they could do the studies in a repeated measure, as we're talking about, do preseason and postseason, that will be helpful. So.
Excellent. And also thank you to the comments in chat. Yes, I agree that standard paper and pencil tests are very nice. They're validated. They are peer reviewed. You don't have to argue about them when you put them in a paper, which is obviously one of the reasons why we use them so much. But NeuroCatch does offer you another way to go. It's an EEG. If you're concerned about it, the novelties, don't worry. I'll use them. They're very nice in my research, but to a reviewer, it's an EEG system, and it just makes your life easy that you can use a system that lets you go out and about. And when you have the most severe kind of disabilities, you can't always ask somebody to explain to you their problems. You can't always ask somebody to even write them down to you.
Yeah.
That does not mean that they don't have neurological differences. Yes, Ryan?
I was just going to say, and the important thing, of course, is that the responses that it looks at in terms of brain vital signs have been in the literature for a long, long time, right? So we have these are extremely well studied responses from, I believe it's sort of first reported 1934 for the N100, and 150,000 ERP studies, right, published in PubMed if you do the search. So what the thing that's exciting is the brain vital sign framework allowed us to sort of, up until now, we always thought, okay, well, why isn't there a vital sign for brain? Brain's complex. We all know, we're all neuroscience aficionados. But the reality is it was a scary thing to look at, but when you actually look, there's a tremendous amount of valuable data that you could extract and simplify into a vital sign framework. And now we're looking at ways of, okay, how can we utilize that to improve our brain health treatments and that sort of thing. So I think that's the main mission, and it's certainly worth us all talking about, because now that we know we can do it, we have to really think blue sky and see, okay, what can we do with this concept?
Yeah, so Ryan, one of the things I want to ask is, when we were first discussing NeuroCatch a year and a bit ago, you mentioned that the base concept was, I can measure blood pressure and heart rate. I can't measure brain function. That's simply to give you a test. And that's what NeuroCatch has tried to do, is that there is obviously a huge amount of difference between blood pressure and neural functioning, but to make a system that provides that information for you. Everything in the background is handled without complexity. I guess one of the questions is, and if the panelists want to jump in on this, well, I've gone for medical exams and, they've taken my blood pressure and my heart rate and stuff. Are we going to start having my medical records are going to have a brain scan for 5 minutes or 6 minutes? Because getting somebody, if I went to a clinic and had a full EEG every time I needed a medical, that's a lot of work. But a 6-minute scan might be something that's quite nice. And also it gives it, one of the things that I was realizing as we were talking is, say that I did have an injury. You've got no clue what my normal is. You have the population's normal, as you've put in the chat. We have a normative for the whole population, but we don't know what mine was. If we can start taking 6-minute scans every year, every 2 years, it gives my doctor, or any doctor who has access to my records, an ability to know what was normal for me in my late 20s versus what is normal for me in my late 30s if I had a brain injury. So Ryan, could you pop in about that kind of idea? What do you think? And like I said, the other panelists is open to you as well.
Yeah, I think we're seeing that utilization in the early days in clinics and research centers throughout. And it is what is really remarkable. The literature told us that these responses were quite stable within an individual. They do vary between individuals, but they were quite stable within an individual. And it turns out that we're seeing that stability is actually delivered based on the research studies above and beyond what we expected in our conservative and worried estimates. So we're seeing quite a lot of reliability. And what's really exciting me these days is just like heart rate variability, the variability we are seeing, we can control for noise and sort of external noise. And we're now getting into looking at brain response variability and how does that indicate in terms of a health metric and that sort of thing. So I think the within subject capability of understanding what is your vital sign and how is that changing is really demonstrating a lot of potential, and we're pretty excited about that.
Yeah, and
I'd like to just also add that the value of the NeuroCatch in eliminating the need for blood tests for young people. I think before there'd be a tendency to want to draw, as I mentioned, some of those biomarkers, NSE, SNTF, and so on. In our case, some of those had to go to Sweden and places for analysis. But young people and most people, period, don't like a lot of phlebotomies and those repeated measures. But so to be able to use a non-invasive technique that yields as much content and gives the providers the insights they need, I think is invaluable.
Yeah, so I'm going to open this up to all of our panel again, as we've talked about what you all individually do, but it's interesting to see how you're progressing. Where is NeuroCatch going for you in the future? Because we've talked about what your scans or what your studies are and some of the more recent work, but what is it looking like, particularly with the world opening? Because there are obviously difficulties at the moment, but where's NeuroCatch going? And whoever wants to jump in, feel free.
Well, I'll take a quick crack since I'm on the sport kick at the moment. I really think that it should become standard use in all of the professional sports that involve any contact. Football teams, as I mentioned, lacrosse, hockey, all of those sports, the martial arts perhaps, but I do think it should become a standard use, because once they've collected baseline data at the beginning of their season and then go into situations where then a player appears to be injured, he's stunned, are we getting, how long is he going to be off for? Does he go to the hospital? All these things. I think the NeuroCatch is increasingly becoming a valuable tool to be part of that assessment to guide the care that's going to follow,
Yeah. So Mike, actually, while Ainsley was saying that about, it's day one and day late, I was thinking that we've talked a lot about the medical side, but I'm curious on just your perspective as a researcher who understands chronic conditions, understands looking how people's health continues. Stress and burnout. Now, these aren't your fields, but do you think as a researcher who looks at chronic conditions, maybe NeuroCatch would be a way to start looking at how people enter into a job or a course and are very happy about that and excited and emailing their parents saying, I started day one, etc. And then in a couple of years, as it's been well recorded, burnout becomes very serious. And what do you think? Could there be a place that NeuroCatch allows for not just studying these medical conditions we've spoken about, but more, psychological cognitive conditions that some of our audience might be more comfortable with?
Great question, but I don't know if I know the answer to that one. That's a tricky one. I think, there's a couple of things that have been mentioned, I think, that are really important points. One is, you go to a doctor's office, you get your blood pressure, you get a couple of tests. Well, those are single moments in time. And we all know that from in medicine, there's a white coat effect. You go get your blood pressure taken, it's probably elevated. So you want to actually reproduce it. You want to actually see, what do you see? And is that consistent with what's the reality, or is that just consistent for that point in time? So having repeated measures in the same domain that is validated that there's consistency is important. So looking at your long-term cognitive function, your ability to focus, to concentrate, and do that in your job, and you're excited about your job, and you're focusing, you're concentrated, you're driven, it's great. And then over time, maybe that peters out for whatever reason. Well, then why is that? And is actually a biological effect, or is that a compounded effect because of other social or psychosocial domains that are coming into your reality that have changed the way your brain functions? And maybe you can pick that up with NeuroCatch. Maybe you can see changes in latency or amplitudes of different waveforms, which would mean it could be representative of your difficulty focusing, concentrating at work, and therefore your performance drops. And that's because that's impacted by something else. it's not a structural brain injury, which is really the domain I work in, but it's kind of the same idea. It's at the end of the day is what is underlying your ability or inability to function in your environment. And is this at a biological level? And if that's the case, is it because of a structural injury, because of an evolving condition, or is it because of other things that are impairing your cognitive function? So, you know, to get to your point, if depression starts to become a reality in your life, I suspect a lot of these measures are going to actually change, because depression does affect your ability to focus, to concentrate, to remember things, all of these things which are biological underpinnings.
Yeah, because I was starting to think as we were talking that, yes, obviously, you know, you have the work that you and Ainsley and Sudan do where you have to go to patients and say, you're injured and for your health, stop. But those are serious occasions, and it's good that people can get the care. But there are many times when people will be in, you know, high pressure jobs, postgraduate life, and their friends and people around them are saying, you seem different, you know, over the last few years, things have changed. Now, it's very known that people shrug that off. They go, I'm fine. You know, it's been a bad week, I'll be fine next week. An actual measure that goes, no, you've changed and you should take care of yourself. I think that we should equally respect that a concussion where somebody can recover also, you know, psychological effects that start, as you've said, Mike, that you'd predict you'd start to see changes in brain function. Having that on a screen so people can see the reality and then be supported appropriately is an area that I don't think there's a lot of support for. You know, most of those treatments are simply done on a, I say I don't feel well, can I fill in a questionnaire? We can start to move that to a more EEG neurological based measure, which I think also anybody in the chat would agree is usually a good thing. That's why neuroscience exists. You know, we wanted neurological measures, not just questionnaires and things to fill in on paper. Yes, Mike.
Yeah, and just to follow that up, I think in the domain that I work in, and it crosses over with Sudan and probably even with Ainsley at some level, is, you know, this entity of PTSD. So a traumatic event, especially in the context of kids that are critically ill in the ICU that we look after, what is the effect of post-traumatic stress disorder on cognitive function? It's not something you can always see, obviously, on an MRI or even an fMRI, but you may be able to see it in brain function. You know, we deal with this concept of good old days bias all the time, where patients will come in and say, oh, I'm not near as good as I was before. And some of that is hard to actually understand because you don't actually know how good you were before, because it's always context dependent. But the ability to do serial measurements over time and look at the delta between there in the context of a precision medicine type of ideal where each person is different and it's the change within the person that's important, not necessarily other things, although the normative data is very important. I mean, this is kind of where we need to get this to if we're ever going to help people as individuals.
Yeah. So Sudan, I wanted to ask a question. Ainsley, I'll get you in a second, I promise. But I wanted to ask Sudan, which is, you study disorders of consciousness, and I think one of the main questions in the field of consciousness, whenever there's a seminar or a lecture, is what is consciousness? You know, that when you say we're looking at, no, and I'm not, I promise I'm being nice, but you know, that we don't know how many normal forms of consciousness there are. Is me having a dinner a form of consciousness separate to me having a drink? We don't know. But I think one of the questions I want to ask then is, does NeuroCatch, and the fact that you can just go grab an undergrad and put it on for 6 minutes and give them a few quid, does that help with starting that you can get not just the normative range that's part of NeuroCatch, but a normative range of what consciousness is? Because as we all know, undergraduates who are probably 18 years old in a lab about to do a study are not the grand spread of consciousness or even research. I know, it's terrible, but we're working with what we have.
Okay, so there are a lot of philosophical questions wrapped into that thing, but I think I will answer that by answering something I wanted to take on from what Mike said and what you've been saying. We've been using the word EEG a lot with NeuroCatch, but I want to be clear that what we're talking about with using NeuroCatch is, for example, measuring the brain's response to cognitive activity. And that's an important distinction between, you know, EEG, the way it's used clinically, where, you know, it can be used to know if you're having a seizure, underlying thing. And it is very much used in the context of, is this person conscious or not in the ICU setting, or much later than that. And the reason I like using cognitive paradigms is because you are probing the brain with something that it needs to do and then recording its response to it. And that's a lot more specific than just, for example, looking at the resting EEG patterns, qualitatively most of the time and saying, I think this is, different, but because now you know what the brain did when it heard that sound, you know what the brain, and you can put numbers on it. Whether that's going to help us answer questions of consciousness is a much deep, thing. I think we're far from answering that as a field. We have, anecdotal pieces of evidence of something looking different on the EEG versus not, but as a field, we haven't done enough to know for fact whether this, you can imagine the context of anesthesia, right? This is a big problem in knowing whether somebody's conscious in different levels of anesthesia. And again, we use EEG, not necessarily EEG responses to cognitive function, which is another place where I think systems like NeuroCatch can help us. But I just leave with this. I think being able to clinically feasibly measure a lot of people as they recover function is going to be key to answering where they started or where they ended up and what their function. Because a lot of people thankfully recover, and that's going to give us clues as to what is the thing that changes in their brain as they recover function to help us understand where somebody might be if they haven't recovered that function. It's
So,
basically
Ryan,
looking under the hood objectively.
So Ryan, as our resident NeuroCatch expert, do you want to take a crack at what consciousness is?
Well, no, I feel I have to defer to Sudan on that one. I think she hit it on the last part for sure, which is that for me, an easier consciousness problem is looking at emergence from disorders of consciousness and tracking that. And certainly our preliminary early data pre-NeuroCatch demonstrated that the importance of looking at these cognitive responses. And Sudan has, I think, some of the most elegant data coming out now demonstrating exactly these sorts of things. And again, not just from NeuroCatch, right? From a host of measures where NeuroCatch is integrated. But I think to your question about what's the future, and I know Adam put up a slide earlier that sort of had a graphic around this. I think what's great is NeuroCatch is for researchers and clinical intervention neuroscientists by researchers and clinical intervention neuroscientists. And what we're doing is we're really paying attention to the incredible feedback we're getting from all of our users to ensure that we continue to put the best possible tool in their hands. And so, of course, we're at NeuroCatch Clinical, which is stage 1 right now. What's excited is coming out shortly in the space of months is NeuroCatch Cloud, where we'll have the report is all fully enabled with radar plots and normative database and a new unveil, which I can't tell you about now, but stay tuned. And then the path that has been demonstrated by all of our users, and we're so thankful, is really to NeuroCatch is a platform, so it's going to go compact and be available on multiple and different EEG platforms. And then integrated in terms of connecting it into different situations, different modalities, and that sort of thing. So I think what's really exciting is it's exactly these sorts of organic efforts to solve this global problem that are leading us to this roadmap of how to best build the tool and get the impact and the feedback that we're currently experiencing.
Yeah, I agree. And obviously with cloud data, we hope that researchers want to use it in an open access way to support open science wherever possible.
That's exactly it. We hope to build something that's open access so the world can crowdsource it and build tools, and we can build up incredible normative databases. Basically, it's about powering up our research capability across the planet. And actually what's cool is we're going now working with CSA and others to go extraterrestrial. So we hope to take it very far.
Excellent.
Well,
Yes,
can I make a comment and ask a question? We missing from our panel is a physician. We aren't represented on this panel right at the moment with
Mike
medical
Ainsley,
provider.
Mike's a neurologist.
Oh, Mike, I'm sorry. That's right. I'm sorry. I was going to say that the idea of having a NeuroCatch in a medical practice in the areas that you're seeing patients, I think is going to end up being very helpful in ERs and things like that. But you might want to build on that, Mike. Sorry.
Yeah, Mike, could you just quickly remember all your medical training for us, please?
Yeah.
Yeah, bring it on.
Was there a specific thing you wanted, like, 'cause I mean, there's a lot of discussion going on. There's a lot of, as Susan said, there's a lot of philosophical ways to think about what the future holds with this. I think the future is wide open. I think this is an ability to look at brain function in real time and see how does that apply. I mean, you know, we have to always be careful that what we know is what we know and what we don't know. So at this point, it's like, there's lots of questions I haven't even thought of that where NeuroCatch may be able to apply, because it's something that's easier for people to do. It's more accessible for other places that can't get at more complicated EEGs or fMRIs or whatever. It allows that kind of collaboration between different research environments, which I think is also important, because what people do in a clinic where they see high throughput of patients, large volume, is very different than what I do. But I'm sure that there's what they see and what they get can be informative for me and for others, because they're looking at a different population. And it's always good to take a step back and say, well, from somebody else's lens, what does this look like?
Well, Mike, I'll cue you up a little bit more. I've always felt, and I've said this often, and it's not been actually controversial in the way it's received, that there's a massive gap between what's available at a clinical frontline, be it neurology or emergency medicine or sports medicine or what have you, around brain care, and what our advanced laboratories in our hospitals and our university labs can do. And the concept is that really what's available today at our clinical frontline hasn't changed dramatically since the 1980s. And I think the goal here is to create the technology connectors that allow that to happen. And so I would be interested in your own experience from a neurology perspective of how you think this can improve your job at the front line.
So good points. I mean, as everybody knows, healthcare is limited by budgets, and every budget is different. So for example, CT scans, relatively cheap, easy to get, but still they're CT, they're radiation, not everybody's a fan of them. And they can only answer so many questions. MRI, great detail, but not easy to get, very expensive. And if they're young kids, you need sedation. Blood tests can be challenging. If you have to outsource them to get the results, you're not going to get it in real time if you don't have capacity. So there are limitations, and medicine is clinical. Medicine will always be clinical first and foremost, but these other tools are helpful. Having something that's readily available, that isn't dependent on extensive resources within a hospital, becomes very appealing for frontline use and for immediate use. And I think working towards those tools and having that capacity is important.
Great.
So as we start to come, if anybody in the audience would like to ask questions, but I guess the final thing to ask is, what is the next study that you guys are all planning to use with NeuroCatch? When you leave this, what's going to be next?
From a research point of view, you said? Yes. Can you hear me?
Yeah.
Okay, sorry, I thought maybe it got muted. I'll just jump in on this if I may. As I've mentioned, we do repeated measure design with the hockey players pre-season, post-concussion, prior to return to play, and post-season. And I'm now moving toward using medication. We have the physicians and so forth on our team, and we will want to be looking at the effect of medication. One particular one by Dr. Dave Doddick, Cynical. We're already starting to use it in some capacities, but we'll be looking to see at how does that affect what we're seeing on the NeuroCatch, as well as the clinical changes, hopefully as well, diminished symptoms and so forth.
I will jump in here. So the focus for us is going to be on tracking the recovery process objectively using measurements like NeuroCatch provides us and other laboratory-based stuff in larger amounts of in larger sample sizes. We basically want to track somebody who's had a severe brain injury from the acute to subacute to chronic settings, pair them with whatever the state-of-the-art cognitive assessments are, And we don't expect them to always match, but that's a reason to do it, because we might pick up something with the NeuroCatch or EEG measurements that are not up at the bedside, and that's important. But more importantly, as a child recovers function, we'd like to know what it is in the brain that's changing to keep up with what we're seeing as clinical recovery, and that's going to be a focus of our lab.
So as we start to finish, Ryan, I would like, if you have any send-offs for our audience, obviously Adam has posted, if you would like to know more, info at neurocatch.com. That will provide some information. I also should point out that we have got information about NeuroCatch on what's called a neuroscience if you would like a in-depth set of episodes, and Ryan's special about his work using research to be able to take it out to the lab. But Ryan, send us off.
Well, I think, yeah, I want to thank everyone. In today's day and age, we are all on Zoom conferences too often, and an hour of your time and attention and effort has been amazing. So I think this has been a phenomenal session and panel. I look forward to continuing on with this, both in the research realms and the clinical innovation realms, but also just in advancing the science and building a global movement to solve the fact that we need an objective physiological measure for our cognitive function. So thank you, everyone. This has been fabulous.
And thanks to all of our guests from around the world. We thank you for staying with us for this whole time. It's been great to have all of you, and we look forward to seeing you. There are going to be more webinars, so please look out for them.
Thank you.
Bye, everyone.
Bye-bye.
Bye-bye. It's a pleasure.